Okay, hello everyone. We're going to go ahead and get started here. Welcome to CortiCare's webinar on LPDs and LRDA. Our presenter tonight is Navita Kaushal. She has her PhD in physiology as well as credentials in REEGT and CST and CLTM. She's been in the neurodiagnostic field for 10 years with 14 years of teaching experience and has been here with us at CortiCare for 4 years, where she is in a role as a manager as well as our continuing education educator. So tonight we'll be talking about LPDs and LRDA, and I will hand it over to Navita.
Good evening, everyone. I'm going to get started. So we're going to talk about lateralized periodic discharges and lateralized rhythmic delta activity. These two rhythmic and periodic patterns are associated with seizures. So the webinar outline, we're going to talk what they are, what are the causes behind these patterns, what are the subtypes, if any, how the EEG looks like, and what is their association with seizures. I'm going to talk a little bit about the imaging studies and what are the differences between these two patterns. Of course, there are some similarities too, and we will discuss that also. And if you have any questions during the presentation, please put them in chat and I will answer at the end of the presentation. According to the ACNS 2021 terminology, this is a list of periodic and rhythmic patterns. So out of this, I have picked periodic discharges, that is, which are lateralized. We're not going to talk about generalized. We're not going to talk about serpids. And then we are going to talk about lateralized rhythmic delta activity. So if you remember looking at this picture, so this is sort of go-to thing, right? It shows these patterns and their relative association with seizures and mortality. On the x-axis here, we have association with seizures, and on the y-axis is the mortality rate. If you look at it, GRDA is a very benign pattern sitting at the corner here, has very minimal association with seizures as well as mortality. However, on the other hand, if you look at bilateral independent periodic discharges, they have very high significance, very high association with mortality rate, about 50% with seizures. LRDA has almost equal association with mortality as well as seizures. However, LPDs is a different story. They have 100% association with seizures. So a patient with LPDs is bound to seize. This is another way of looking at it. In this model, we are talking about different patterns and what is the seizure risk. As the frequency of these patterns change, the risk for seizure changes. Now, if you look at it at the bottom here, GRDA and GRDA plus, it has whether it is 1 hertz or 2+ hertz, the seizure risk is very minimal. With the LPDs and LPD plus, we have the highest seizure risk as their frequency increases. Even at 1 hertz of LPDs and LPD plus, the risk for seizure is high, but it gets higher as the frequency of LPDs or LPD plus increases. When the LPDs start to present themselves with plus modifiers, we'll talk about them in a bit, the risk for seizure increases. LRDA and GPDs plus, they lie next to each other. GPDs as such do not have higher seizure risk, but if the GPDs present with a plus modifier, the risk for seizure increases as the frequency of the GPD plus increase. The graph that I showed you was from a multicentral cohort study where they have close to 5,000 critically ill patients. And they pull the data together, which shows that lateralized discharges are associated with seizure almost at all frequencies, but the risk increases with plus modifier. LRDA and GPDs, they are associated with frequency with seizures when their frequency increases from 1 hertz to 1.5 or more. However, SERPIDs are not associated with such risk. Now, it's been over 10 years that we have changed the name for these periodic discharges and this rhythmic pattern, right? It used to be PLEDS, and I'm sure many of us are still using it subconsciously. 10 years in the making, we still have to get used to it, right? So the term epileptiform was taken away because it was sort of an ambiguous term, so PLEDS became LPDs in 2013. Same thing happened with FERDA and TERDA. We are not using those terms. We are using rhythmic delta activity, and then you specify the location. That is the new terminology, which tells you how to describe a rhythmic pattern. So if you have rhythmic delta activity at temporals, you will be describing it as temporal rhythmic delta activity. Now, if it is generalized or it is lateralized, you are going to mention that too. So those are the main terms in the new ACNS terminology. So over the course of this presentation, I would still bring the term PLEDS because that's how the terms were initiated and how we were explaining earlier. What's the pathophysiology of these patterns? It is not fully understood. Whatever understanding we have that tells us that there is hyperexcitability of one particular area of the cortex. So basically focal cortical hyperexcitability. There is an injury or an insult due to multiple reasons to cortex, and the white matter around the cortex, cortical structures, and deep gray matter of the deeper structures. There is a disconnection between the cortex and the subcortical structures. Mostly thalamocortical connections get damaged. They are the reason that patients start to present with LPDs and LRDA. All right, let's talk about LPDs. The term PLEDS was introduced in 1964. Those were the paroxysmal sharp waves repeating periodically or quasi-periodically, and they were separated by periods of inactivity. The definition still stands, but we are using the term LPDs now. There are acute, subacute changes in the neural tissue in the brain, and there are this pattern is due to lesions or focal injuries on the ipsilateral side where you are seeing these discharges. Now, are these LPDs ictal, interictal, or are they part of interictal continuum, or they are all of the above? I think we are sort of having a very better understanding of what they are, at what frequency, what should we categorize them as. Jalise et al., they introduce a term called periictal. That is something that when a patient in ICU, a critically ill patient in ICU, shows presence of LPDs. Now, are these LPDs associated with seizures? It's a concept, right? Are these LPDs associated with seizure? That patient who has certain frequency, morphology of these discharges, do they need to stay on long-term monitoring? Should there be change in anti-epileptic drugs so that the patient does not go into status? So the pattern, the morphology of the LPDs kind of define them in periictal mode. And based on that, we kind of address the clinical situation. There are subtypes of periodic discharges, LPDs proper and LPDs plus. We'll come to those subtypes, but let's talk about the causes of these LPDs. The major cause behind this is infection, stroke, and traumatic brain injury. And if patient has epilepsy, mostly focal epilepsies. Less common causes are post-anoxic and toxic metabolic encephalopathies, CJD, even demyelinating diseases, and so on. The list goes on for less common causes. Now, temporal LPDs have very high prevalence towards seizures. And temporal epilepsy, we see most 70+% cases of epilepsy are temporal epilepsies, right? So CNS infections, especially the HSV encephalitis, it produces LPDs in the temporal area. So there's a high correlation between infection and LPDs. Different variations of these LPDs. The term used to be PLEDS proper and PLEDS plus. We're going to talk LPDs proper. So these are the periodic discharges. They are not rhythmic. So these are LPDs without rhythmicity. And LPDs plus, this is different from a plus modifier. This term LPDs plus is not a plus modifier, which I'm going to talk in a few seconds. So LPDs plus variation is the LPDs with rhythmic discharges. They have high correlation with seizures. When you see the term plus next to LPDs, it means the pattern is more ictal appearing. This plus is not limited to LPDs. It is used with other patterns too. Plus modifiers, plus F, which is periodic discharges with superimposed fast activity. The closest example I can give you is like polyspides or polysharps. Plus R is superimposed rhythmic activity alongside these periodic discharges. So plus F, plus R, they can appear independently of each other, or they can occur together with the periodic discharges. So you can have LPDs plus F, you can have LPDs plus R, or you can have LPDs plus F plus R. Another plus modifier is plus S. That means a sharp activity. Now, LPDs are already sharps and spikes, right? So you're not going to use plus S modifier with LPDs. That modifier is used with RDA. So GRDA plus S or LRDA plus S. That's where you use that term. Let's look at some of these examples here. So the top example here is LPDs proper without the rhythmic discharges. Then you have LPDs plus. These LPD plus is usually seen in herpes simplex encephalitis. And then you have LPDs max. So LPDs plus and LPDs max have very high correlation to seizures. So in LPDs max, you will see periodic discharges with faster frequencies and attenuation or suppression in between. These are some of the examples of LPDs. So when you are describing them, you will talk about the frequency, you'll talk about the morphology, and the localization of these. So these are left-sided lateralized periodic discharges of spike wave morphology and a frequency of about 0.6 hertz. Here is another example. This looks more like LPDs plus F because there are faster frequencies alongside these periodic discharges. This is unilateral independent periodic discharges. If you look at it, the frequency of the discharges on the left and midline is very different. So these discharges are independent of each other. They are categorized according to the new terminology as unilateral independent periodic discharges. The frequency is less than 1 hertz at midline and between 1 to 1.5 hertz on the left side. So here is example of LPDs with plus modifiers. So with superimposed fast activity. Up here on the right side, we have some muscle spikes here. That's an artifact. At the bottom here in the frontotemporal region, LPDs with fast activity. So this would be categorized as LPD plus F with a frequency of approximately 1 hertz. Here is another example of LPDs with rhythmic activity. So if you look at it, you have these sharps and a rhythmic delta following that sharp. So here we have a plus modifier, about 1.5 hertz of LPD plus R. So this pattern will be categorized into interictal continuum. Let's talk about the subtypes. We're not talking plus modifier now. We are talking subtypes of LPDs plus. LPDs max, this pattern it is not IIC pattern. It corresponds to focal non-convulsive status epilepticus. The frontal lobe is paired. So if you are seeing these LPDs, they are absent on the frontal lobes, but they are seen on the temporal, parietal, and the occipital regions. This pattern is refractory to anti-epileptic meds. There are 2 variations of this pattern. One pattern is with polyspike wave, and another pattern is a focal burst suppression-like pattern. It is not a burst suppression pattern, but it is a burst suppression-like pattern where you would see attenuation or the suppression of the signal in between the discharges. Now, these patterns, they may or may not be associated with motor signs. Most of the seizures that patients have with LPDs, they have very minimal motor involvement or they are subclinical. So we'll talk about the reason for that. So here is an example of LPDs max of periodic polyspike wave activity. So this is a 62-year-old woman with a history of chronic alcohol abuse. This image is taken from the, as you can see, there is a reference at the bottom here. Patient had right hemianopsia, aphasia, and then the imaging study shows the hypersignal at the occipital. So if you look at the image here, EEG here, the discharges are maximal at the posterior half of the head, not in the frontal lobe. So these are categorized as LPDs max. And here is another example. It is burst suppression-like pattern in a 56-year-old man, diabetes, history of diabetes, generalized tonic-clonic seizure, and left hemiparesis. EEG is done 2 days after admission, and if you look at that, the patient is having LPDs, and in between the LPDs, the background is suppressed. This is a refractory pattern, not responding to any anti-epileptic drugs. According to this paper, the patient passed away of cardiac arrest, which was independent of his condition of the EEG that you are looking at. All right, another example of focal burst suppression-like pattern. Again, it is not burst suppression. You see the periodic discharges and suppression attenuation in between them. What are the neurological symptoms? So especially when we are categorized LPDs or ictal, or if we say the patient is in an ictal state, what clinically do we see in those patients? So patient definitely has neurological deficits like hemianopsia, aphasia. There are motor deficits. There may be no structural abnormality. So all those signs, they point towards periictal or ictal. If there is a mental confusion, so mental confusion, do not take it something like impairment of awareness due to stroke. We're talking mental confusion where patient has an impairment or loss of awareness of their surrounding, place, time, and the situation. So those patterns will be classified, categorized as ictal. Now, irrespective of the frequency, if you see the LPDs are time locked with clinical features, they are ictal, irrespective of their frequency. Epilepsia partialis continua, they're time-locked or not, LPDs are ictal. When the LPDs are followed by nystagmus, where it's a different kind of, it's not vertical or horizontal nystagmus, it's where both the eyeballs, they rhythmically converge and then they retract into the orbit. And the patient appears to having an outward gaze. So it's a very strong clinical sign of subtle seizure, and that those LPDs and this clinical sign mixed together is an ictal pattern. What's their association with seizures? First of all, what kind of seizures are there when we see LPDs in a patient? The seizures can be subclinical, can be focal motor, epilepsia partialis continua with occasional secondary generalization. Sharpness of the LPDs, it has a big role in defining whether the pattern is ictal or not ictal. So sharp or spiky LPDs have higher association with epileptic seizures compared to LPDs which are blunt. Low to medium amplitude of LPDs fall into periictal category. However, high amplitude LPDs, they represent an index of epileptogenicity. They may not be epileptic unless they are sharp. So high voltage sharp LPDs are categorized as ictal. Now the frequency of LPDs. LPDs of more than 1 hertz with the plus modifiers, they are categorized as ictal. 0.5 or less are interictal, or it represents some irritative brain injury. LPD plus F, LPD plus R, 1 hertz is ictal. With clinical symptoms, when the LPDs are presented, they are time locked with a jerk or a twitch. They are ictal regardless of their periodicity. I learned that interictal continuum term was proposed for LPDs. Now we are using that term with other patterns too, but in 1996, this term was introduced to be used with LPDs. So what is interictal continuum? Any periodic or spike wave pattern averaging 1 hertz to 2.5 hertz over 10 seconds. So we have not gone to the 3 hertz mark, right? So we are between 1 to 2.5 hertz. A periodic pattern is categorized as ictal interictal continuum. And now if we have a plus modifier attached to those PDs, whether it is the faster frequencies or the rhythmic activity, now the frequency decreases. The frequency of PDs with plus modifier is 0.5 to 1 or less than 1 hertz for 10 seconds. So that would categorize as ictal interictal continuum. Just to sum up the comparison of different types of LPDs. So you have interictal or brain injury representing LPDs proper. Their periodicity or frequency is 0.5 hertz or less, and they are more or less of monomorphic looking. Periictal and ictal LPDs are with the plus modifier, and LPDs plus. They fall into periictal and ictal category too. Periodicity is 1 hertz or more, and if you see that they are evolving in location as well as in frequency. Any neurological signs that we saw before, and neuroimaging results. We're going to talk about that in a few minutes. The second pattern is lateralized rhythmic delta activity. Very old research papers are talking about this rhythmic pattern as unilateral or asymmetric FRDA. The term IRDA, the intermittent rhythmic delta activity, we don't use it anymore. was described in 1945 to discuss the rhythmic slowing. So what is LRDA? It's a unilateral, so it's lateralized, right? Lateralized, it's sticking to one side of the brain in one hemisphere. So a unilateral repetitive waveform with nearly uniform duration and morphology recurring up to 3 Hz without measurable inter-waveform interval. It should appear at least for 6 consecutive waveforms to be defined as LRDA. So if it is happening in less than 6 cycles, it is not lateralized rhythmic delta activity. LRDA always occurs in short runs, unlike LPDs, which can go for days together. LRDA is for a few seconds to 30 seconds, or at the max for a minute or so. It's not as common as LPDs. 5% of critically ill patients with altered mental status in ICU will have LRDA. And little less than half of those cases are associated with LPDs. So even if LRDA is present in critically ill patients, it's not coming by itself. There is presence of LPDs in almost half of those cases. The pattern LRDA is of anterior predominance. This is highly associated with seizures as equally as LPDs are, but still there is some debate saying that LRDA is not as significantly correlating with seizures or prevalence of seizure. But some research, some scientists, or they're still talking that it is almost the same. So we still have to get 100% confirmation that it is. The causes of LRDA are more or less the same of LPDs. So I don't have a detailed list here. So intracerebral or subarachnoid hemorrhage, tumor, traumatic brain injury, infection, or focal lesions. So it's not encephalopathy. Those are the focal lesions, which causes LRDA. There's a big difference between focal non-rhythmic slowing and lateralized rhythmic delta activity. LRDA, these are two different EEG phenomena. There is completely different physiology going on underneath to produce these two patterns. The rhythmicity is the one that is calling the shots here, right? Once you have rhythmicity in the pattern, the clinical implications are totally different. LRDA is independent of focal non-rhythmic slowing, and it is an independent predictor of recurring seizures. Risk of seizures is high with LRDA compared to focal non-rhythmic slowing. LRDA is due to lesions in the brain, which involves cortex, areas around the cortex, the white matter, and deep gray structures. However, the non-rhythmic focal slowing, some of the reasons are subcortical dysfunction. So usually it is the thalamus that has some sort of an insult, some sort of an injury or abnormality in the thalamus, which projects to cortex, and there is focal slowing, which is non-rhythmic. So more or less like polymorphic delta slowing and things like that, but it is not rhythmic. The EEG characteristics of LRDA, first of all, the background is asymmetric. The pattern is monomorphic from medium to high voltage, 50 to 200 microvolt. It's sinusoidal, sharply contoured delta. It can be brief, as less as 1 second, less than 10 seconds, and longer runs, some studies have shown up to 30 minutes. The typical frequency of LRDA, we know it's delta, but most of the time we are seeing 1.5, 2 hertz, and sometimes 2 to 3 hertz. Occasionally to rarely, we will see 3 to 4 hertz of 3 to 4 hertz of rhythmic delta. And it presents with plus modifier. It can present it with plus modifier, which is the faster frequency. So LRDA plus F, you have superimposed fast activity. and LRDA plus S, so rhythmic delta with sharps embedded in it. So here is an example of LRDA. Here is another example of left-sided LRDA in patient who is fully awake. Here is patient in ICU, LRDA plus S. I would still call it, there are faster frequencies, but the source of this EG pattern says this is LRDA plus S. But if you ask me, I'm going to label it as LRDA plus S plus F. Here is asymmetric LRDA. So this is unilateral independent LRDA plus F. If you look at it, the frontocentral parietal versus the temporal. So we have two different types of rhythmic delta, slower on the temporal compared to the frontocentral areas. So unilateral independent LRDA with superimposed faster activity. The clinical correlates of LRDA is patient is clinically stuporous or comatose, altered mental status. There are focal deficits. However, there are no obvious clinical manifestation of this pattern. Neurological exam is localizing and it is consistent with the side of LRDA. So you will see the deficits, whatever side the LRDA is appearing. Association of LRDA with seizures. Most of the seizures are acute and it is a focal onset. So if you see bilateral asymmetric lateralized rhythmic delta, so if you're seeing on left and right side, I know it may categorize as generalized rhythmic delta, asymmetric GRDA, but you have to look at the rhythmicity and the voltage. So you can have two seizure onset, two foci in that patient. Another thing to remember is to keep in mind is localization is not a significant seizure onset factor for LRDA. However, temporal rhythmic delta has a very high prevalence for seizures. But if you're seeing frontal LRDA, patient may still have temporal seizures. Plus S modifier and faster rates of LRDA. If the LRDA is greater than 2 Hertz, and if it is appearing with plus S modifier, the chance of seizures, the risk for seizures would increase. The seizures are non-convulsive. With LPDs, you may still see some motor manifestation, but with LRDA, it's rarest of rare that there will be motor involvement. There is very minimal motor involvement if there is any. The reason being, there is a dysfunction between the cortical and subcortical network, right? So that is not letting any ictal activity propagate through the motor pathways, to produce motor activity during the seizure. So that's why even with LPDs and LRDA, their pathophysiology is more or less the same, right? So that's the reason we see none or very minimal motor involvement in seizures with these patterns. Here is a graph which shows the prevalence of the incidence of percentage of seizures in patients. So the study is conducted by Gaspard et al. So in this, let's look at the top graph here. You have controls, you have patients with focal slowing, and patients who are presenting with the LRDA in their EEG and LPDs. Now, if you compare the incidence of seizure during the first hour of monitoring, these are all critically ill ICU patients. So if you look at that, so incidence of seizures in patients with the LRDA pattern is about 22%. And with LPDs is about 25%. So there is not much significant difference between these two patterns. But if you compare these two patterns with focal slowing or with control, the difference is significant. So that says that these patterns are they're the high-risk seizure patterns, right? And let's discuss the bottom graph here. So here you are seeing electrographic. The dark blue-green is electrographic. And then we have both kinds of seizures, slightly light of this greenish color, and the lightest of all is always clinical seizures, right? Again, let's compare LRDA versus LPDs. So 80% patients with, so this is the entire recording. So 12 to 24 hours of recording. If you see 80% seizures in LRDA and about 85% in LPDs. Again, it's not a significant difference to say LPDs have higher prevalence than LRDA, right? But if we are comparing this to controls in patients with focal slowing, of course, there is a high prevalence of seizures in patients with these two patterns. What does the imaging study show? There are lesions in the cortical and subcortical structures ipsilaterally to the pattern. These lesions are present in white and gray matter, but less often in white, and gray structures, deep gray structures are more involved. There is no significant difference when we compare both these patterns and the localization of the lesions. No difference in the structures involved. There is a spelling mistake here. Cortical and subcortical regions are less involved in GRDA. And the imaging study is normal with patients who have GRDA pattern. Then the focal pathologies, of course, both the patterns are showing more or less the similar pathology like ICH, ischemic stroke, neoplasm, TBI, subdural hematoma. And another thing is both the patterns have high prevalence of seizure during MRI. So whether a patient with LPDs or an LRDA, you are monitoring and that patient goes to MRI, comes back with seizures one after another, or maybe patient is in status. So somehow during MRI, both the patterns are causing higher prevalence, just producing seizures, more seizures. No one is less than other, right? The PET and SPECT scans, they also show that there is increase in cerebral perfusion at the area, at the focus for LPDs. There is an increase in cerebral perfusion there. As the frequency of the LPDs increase, the metabolic demand or the metabolic activity of that particular area also increases. It increases even 100 to 309%. So which shows involvement of those areas in the brain. The most amazing thing is these two patterns, they get together. They go, even if you are seeing one pattern at one time and you are like, no, there is LRDA, no, there is LPD. So somehow these two patterns do get along. So patients who are having lateralized periodic discharges, you will see them having LRDA. More of LRDA and less of focal non-rhythmic slowing. Similarly, if a patient is having LRDA, you are going to see patients, you are going to see LPDs in that. However, focal non-rhythmic slowing, it doesn't overlap. So patient with LRDA can present with LPDs, and patient with LPDs can present with LRDA. So these two patterns sort of overlap. And in a study where they did the simultaneous recording from the scalp and from intracranial, so on the scalp EEG, there is RDA, and from the intracranial recordings, they are seeing LPDs pattern, periodic patterns, or periodic bursts. So epileptiform discharge is intracranially, and on the scalp EEG is LRDA. So does it mean that this pattern originate as a periodic burst or an epileptiform discharge in the deeper areas of the brain, and as it propagates to cortex and you pick it up with your 10/20 system, it appears more as lateralized rhythmic delta instead of appearing as periodic discharges. What are the similarities? Well, they both share almost same pathophysiological mechanism. Clinical and radiological correlates. They both have high incidence of acute seizures. The anatomical distribution was similar. However, LRDA, they both have brain lesions, and LRDA is somehow a little bit more than LPDs. The differences. What I learned is LRDA, it reflects more of a functional and a dynamic process, but the LPDs is due to permanent brain injury. It is something static in the brain, in the brain, and that's why we see LPDs. They may occur independently, but they coexist at the same time. LRDA usually occurs in short runs. It may go as high as up to 1 minute, and LPDs, they can run for days, for minutes to hours to days. Frequency of LRDA is 1.5 and 3 hertz, and LPD frequency is usually 1 hertz or closer to that. Still, it is still debatable if LPDs have higher seizure prevalence, but the studies that I have presented, and I have put together this presentation based on, there is not much difference. Even if there is a little bit more prevalence with LPDs, it is not significant. This graph is from Johnson and Kaplan, this table. It shows association with seizures. So if you look at the top here, lateralized periodic discharges have 50 to 100% association with seizures. The mortality is 24 to 41%. Compared to LRDA, so on the fourth line here, you have 25 to 63% association with seizures. So this is like a little different than what we talked before. That's why I said it is still debatable. The community still thinks that LPDs have higher risk for seizures compared to LRDA. What's the treatment for this? There is no clear guideline. The whole idea is to avoid patient getting into status epilepticus. That's why the concept of periictal LPDs or periictal patterns is being promoted so that the clinicians, the neurocritical team can identify that, okay, these PDs are going to evolve into seizures and maybe patient will get into non-convulsive status epilepticus. So it's basically to treat, to control them. And of course, the imaging study and the SPECT and PET can help, gives an idea that, okay, there is an increased blood flow, there is hyperperfusion, increase in metabolic activity in those areas. So that could be an epileptogenic zone, which these LPDs can evolve into status epilepticus. So as of now, there are no clear guidelines exist to treat these patterns. All right, take-home message. We talk so much about the similarities, the differences, pathophysiology, different kind of EEG waveforms, and things like that. The background is asymmetric. Okay, there is focal slowing, there is polymorphic slowing, and there are sharps and spikes. So the EEG is abnormal, right? There is suppression and attenuation of the background. Both the patterns, you see them, there's high prevalence for seizures. So even if I say it's debatable, both the patterns are going to lead to, if they are not attended properly, if they are not taken care of, the patient is bound to seize. You expect to see both the patterns. Sometimes they are interchangeable. Sometimes they both are present. Sometimes it's hard to say if it is LRDA plus S or it is LPDs plus R. So that's when you rely on the terminology. Look out for plus modifiers. You see a modifier, the prevalence for seizure is high. The seizure risk is high in those patients. These patterns can be dynamic. Like I said, they can be interchangeable too. I think this is my last slide. These are the sources. Some of these are abstracts. I had to request the full articles, and some of these are full articles. Feel free to read them to get more insight of these patterns. Any questions? If you have any questions, please put them in the chat. So Jean is asking, is there a higher prevalence for seizures with stimulus-induced increase in LPDs? Again, you have to look at if the stimulus-induced LPDs, what's their frequency, what's their morphology, and if there are plus modifiers are associated with it. I have seen some neurocritical care team, they are not very much bothered with stimulus-induced pattern. I mean, if it happens for 10 seconds, yes, it's an event, it's a seizure. But if they subside, if they are no longer present after the stimulus is gone, they are not worried about it. Do they treat it? Yes. So again, look at the plus modifier, look at the increase in frequency, morphology, their voltage and amplitude.
Yeah, Pat, you can go ahead and ask your question if you have one.
Yes. My question, first of all, thank you, Navita. It was really lovely and excellent. So thank you.
Thanks, Ben.
I am wondering if this is available someplace on 365 Microsoft so that I could periodically go back and play it back and review it a little more carefully because sometimes I'm a slow thinker.
Brad, you want to take that?
Sorry, I'm reading some of the questions in the chat.
Okay. Yes, Pat. So this will be available internally. It will be available to CortiCare staff. And I think it takes about 48 hours for it to get into a video form, and we will share it with all the presentees. They will get a link to the presentation. But for the CortiCare staff, we will put it internally onto our Microsoft.
That's beautiful because there's a lot of it was excellent information and well presented, but it's a good deal of information and a lot can be learned from just going back and looking at some of the graphics, looking at some of the statistics. So it's quite good. Thank you. You've answered my question.
Thanks, Pat. There is one question here, LPDs and BIRDS differences. The way I understand BIRDS is seizure fragments. So when the LPDs increase in frequency, they change their morphology and they appear with plus modifier, but they are less than 10 seconds, that qualify as BIRDS. So those are brief intermittent rhythmic discharges. Less than 10 seconds, any evolution of frequencies or morphology or plus modifier, those LPDs, you can term them, you can tell them as BIRDS. Lisa posted something. Can we look at this lecture on site? Can you elaborate on that, Lisa, please? Yes, Jean. This presentation is ASET 1 CEU approved. So once you get the form, the survey, post-webinar survey, please remember to fill it. That's what will be submitted to ASET for you to get CEU. Yes, Lisa, once we have this presentation will be in a video form and we will post it on our YouTube CortiCare channel. You can access it from there. Christina, yeah, so after MRI, patients with LPDs have increase in seizures. During MRI, I mean, yes, it is a stimulus-induced kind of a thing. I still want to learn more about it, but when we monitor, we have seen patients who come back, patients with LPDs and LRDA, when they come back from their imaging study, their pattern changes. So they are more malignant than before. They may be having some sporadic LPDs and now they have continuous LPDs. And if they had 1 Hertz LPDs, they have increase in frequency now. They may be having bursts. Does that pattern last forever? Yes and no. But somehow, I do not have a data to tell you how many patients would show that. But as a monitoring tech myself, I have seen when a patient, for a critically sick patient, goes for MRI, they come back. I would say 50%, my personal experience, they will have change in pattern. They may even cease. And they are ceasing during MRI too. But yes, it is something I would like to, like what's out there in the literature. I would like to know that. Jean, I think it is, I personally feel it could be too much stimulus to the patient, transporting them, moving them to the MRI and things like that, right? It could be stimulus or it could be more than that. Maybe that die. Like I said, I would really like to learn more about it. First, I used to think it's just me who feel that way, but when I was studying for this presentation, reading for this presentation, it came up there. So I would really, I will explore that. That's an interesting theory. Could be protons are turned in one direction. It could be the magnetic fields of the neurons. That could change. Could be. Yes, I agree with you, Pat. Pat says in some animal studies, MRI can cause subtle changes.
All right, everyone, I think we're going to go ahead and wrap it up here. Thank you very much for coming. Thank you, Navita, for an excellent presentation. And keep your eye on your emails for the post-webinar email that'll give you a link to the evaluation as well as a link to the replay of this recording. Other than that, everyone have a good rest of your day.
Thank you, everyone. Have a good night.